My name is Ingrid Ainalem, and I also work at the Center for Innovation and Improvement. My profession is district nurse, and I have a Master of Science, and I have done research and improvement work, some of which I would like to present to you today. And Adam?
My name is Adam Roth, and I'm a medical doctor, and I've done research into epidemiology and international health. And now for several years I've been working with the Center of Innovation and Improvement. And I'm going to work as a facilitator here today because we want to have an interaction with you today where we discuss sustained improvement work and how to evaluate sustained improvement work.
Yes. And Region Skåne is one of 21 counties in Sweden, and it's responsibility for health of about 1.5 million inhabitants in Skåne. Skåne itself is divided in 33 municipalities, with 9 hospitals and a great number of primary care centers. Skåne University Hospital you find in Lund and Malmö, and Malmö is the biggest town and the gate out into Europe and out to you here today. An important task for the Center of Innovation and Improvement, among other things, is to promote a tradition of continuous improvement by supporting and encouraging creative ideas among fellow workers. So, again, a warm welcome to this session, and please, Adam.
You can take the next slide. Yeah, so the agenda for today, welcome, just come in. The agenda for today is that Margareta is just giving you the organizational background, so to say, in which we work. But we want to bring it more alive to you. So we can't bring all our teams here, I'm afraid. But we brought some of them with us with films. So we're going to have 3 films that you're going to watch. And this is really, the films are going to demonstrate some themes that we're going to talk about all through this session. Please, Margareta, the themes.
In our center, we are inspired by Edvard Deming. And these 4 points are based on all our systematic improvement work. Start out for the customer's demand. An active collaboration, active leadership, and system understanding. So, Adam.
Yeah, so if we go back to the agenda, after the first film, you're going to see Ingrid talk about her research results on how to evaluate sustained improvement. And then we're going to, in several sessions, have some few discussions where we want your input also so that we can learn. Learning is the best, teaching is the best way of learning, we think. So we'll try to follow that also here.
Are you starting the film? Or?
Yes, I can start that one. And the first film, we really think will demonstrates the 2 points from Deming of active collaboration and also system engagement. This is one of our the teams that we're really proud of. So please meet the team from Child Clinic in Kristianstad.
Skriv innovationerna vid behov. Jättejobbigt med fel tider.
Ja. Nej, men det är mycket bättre att ha det så att vi själva kan sätta in det. Eftersom ofta tiderna inte stämmer och man blir förskjutet.
Och så har vi ju sagt innan. Ja. Vi är lite nya läkare, så jag tar det på nästa läkarmöte. Vi har läkarmöte snart.
Barnavdelning 43 på Centralsjukhuset i Kristianstad är en allvårdsavdelning för barn mellan 0 till 18 år. Det innebär att vi har rätt så stora krav på att vara mångkunniga, och vi möter ju familjerna hela tiden, inte bara patienterna som är barn. 2008 när vi startade vårt förbättringsarbete hade vi fått rätt så dåliga resultat i en patientenkät. Arbetsmiljön upplevdes som stressig och vi kände att vi måste göra någonting åt det. Vi valde att starta enkelt. Vi skulle inte krångla till det, utan detta var något som skulle sätta sig fort, tyckte vi. Och skulle vara lätt att jobba med. För att det är så himla viktigt att det är medarbetaren själv som jobbar nära patienterna som ska hitta problemen. Och det är de som har de bästa lösningarna.
Jag tycker att vi blir färdiga snabbare än rondarbete nu. Och så tycker jag att prioriteringen på tavlan fungerar jättebra nu. Så går vi runt till patienterna i rätt ordning och kan visa provsvar och visa röntgenbilder direkt på datorn. Och det fungerar också jättebra. Innan var det som så att man kunde få ronda med 3 olika barnsköterskor och sjuksköterskor. Men nu rondar vi bara med ett team och det är ju bara fördelar med det. Alla är ju dessutom mycket pålästa när de kommer till ronderna nu, vilket de inte var tidigare. Och det är också en stor fördel.
Jag känner mig mycket mer delaktig i vården idag, speciellt på ronderna och en del i teamet. Jag har lättare för att göra min röst hörd och man lyssnar på mina åsikter.
Ja, sen har vi ju haft den här stora städningen och det har också gjort att det blivit mycket lättare att hitta. Och sen vi märkte hyllorna så behöver vi inte leta i pärmar för de har vi också rensat bort.
Förbättringsarbetet på vår barnavdelning med den här genomgripande förändringen av vårt arbetssätt har inte skett i ett enda stort steg utan i många, många små. Det har varit grundat på medarbetarnas egna förslag och idéer, men en stöttande och tillåtande ledning har varit en fullständig förutsättning för att det här ska kunna ske överhuvudtaget. Förslagen har dessutom fått en egentligen ganska omedelbar återkoppling, vilket jag tror också har varit en förutsättning för att man ska orka fortsätta ställa förslag. Det har också gett en väldigt stor delaktighet. I det här utvecklingsarbetet har alla personalkategorier varit delaktiga, inklusive läkarna, och det har varit oerhört viktigt. Jag ser nu medarbetare som tar ansvar för att utvecklingen drivs framåt och ser det som en naturlig del i sitt dagliga arbete.
Vi har kört detta sedan 2008 nu och det verkar som det har satt sig. Man tycker att det är ett sätt som fungerar, man känner sig delaktig. Man tar ett mycket större ansvar för sin egen arbetsplats och för dessa utveckling. Och som chef är det jätteroligt att jobba med detta. Jag behöver bara vara den som stöttar, jag är inte den som ger besluten.
So, I think we'll do some baseline measurements, like you always have to do. We'll do that in this session also. Just so that we know, how many people here in this room recognize themselves as a team member, such as these people, that they have worked in teams working with improvement work? How many of you? And that's quite a few, at least 70%. It's a good measure. How many of you understand the Swedish? Oh, that's less. I'm happy. Hopefully more people understand the English. I won't even ask that one. If you look at then Margareta and Ingrid, they're really professionals with working with teams. They've done this for a really long time. They have followed and collaborated with very many teams. How many of you in this group have done that, having many teams that they collaborate with? That's quite a few also. That's really good. We'll have a good discussion here, I think. Okay, so before we go any further, just let's hear your results,
Yes.
Ingrid, or
Thank you.
your study.
So, when coaching teams and organization in improvement work, you might have asked the question, will there be any results of all this work? I mean, what happens after a couple of years? Did the improvement program deliver results? I am now going to present to you a report that Agneta Berg, professor in healthcare, nursing and science at the University of Kristianstad in Sweden, and I have done to evaluate the improvement work. We have followed as many as 51 of 53 teams during a period of 3 years, from 2007 to 2009. And I'm going to focus especially on the long-term effects of improvement work. The design of Center for Innovation and Improvement programs extend over a period about 10 months. And it consists of about 5 or 6 working shops. Each working shop extend over 1 or 2 days. In the time between the working shops, the teams do hands-on improvement at home, at their own working places, like measuring or testing new ideas for change. Each team is assigned a facilitator from the Center of Innovation and Improvement. And all the facilitators are fully acquainted to the improvement theory and all the improvement processing tools that form part of the program. So the aim of this study was to examine the significant and long-term effects of improvement programs for units and organization that completed training after the program. And this was during 2007 to 2009. And to do this, we use the IHI assessment scale, 0 to 5. And Adam, can you please tell us something what it is and how we used it?
I'll try. So we've made a Swedish version of the IHI assessment scale, of course in collaboration with IHI, so that it fitted our system better. So if you see, this is the scale. It's increments from of 0.5 steps, and then it goes to 5. So it's actually a 10-step scale. So this, what you see here, is a translation of the Swedish version into English. So, but it's to fit our setting. And it's a scale where you have to reach one level in order to go to the next, so to say. How many people have worked with the IHI scale in here? That's still a few, like 10 people around like that. But that's interesting. We'll talk more about that later. But generally, you can say that if you summarize the different levels, in the first level, it's about forming a team. And the second level, you've started activities, but you really see no changes yet. And then at 3, you see modest improvements. Whilst number 4 is a step where you say, well, here we really have changes, here we have significant progress. And as you can see, evidence of sustained improvement of outcome measures, that's the 4. It's an important number because in many studies from the IHI, for instance, it's because this was developed, the tool was developed in '95 by Tom Nolan in the Breakthrough series. So there are several publications where they've used this scale, which is really a benefit, I think. And there you say that if you reach a level of 4, then you say you've reached a significant improvement. And Ingrid has the same level, the same value. And then if you reach number 5, you say that you reached outstanding results. You've spread results not only within your working group, but to other patient groups and such. So that's really the scale. And the thought with it is that you should be able to follow the teams and so that you can communicate rapidly how it's going, so that you can change the improvement work and the improvement program and act if you see that the team is not going well, and so to say. So the thought is that you should go straight up during the improvement program. But generally, in the studies made, you haven't really measured much time after the improvement program. So you measure to the end of the improvement program and then you stop. But Ingrid is going to present to you some other results.
Well, How did we collect data? We collected data for, we had 51 of 53 teams. I mean, that's a rather high participation, I think. And we collected data during February, April, and springtime 2010. And we collected in 3 ways. Self-assessment, carried out through the teams and the managers by their own evaluation according to the assessment scale. And parallel to this, the 15 facilitators made their own evaluation according, of course, to the assessment scale. And finally, we made structured interviews with all the teams and the managers during this time. So please notice that the assessment was made at the same time in spring 2010. But there were many programs going on. We choose to assess the teams after completed programs because we were trying to find out the long-term effects of improvement work. So as you can see, some teams finished their programs 3 years ago from the assessment, and others 2 years ago, and some only 1 year ago. So if we look at the 30 participants, you can see the programs, the different programs, and you can also see the profile of the programs. And as you notice, the half of the programs, that means half of the teams, 25 teams had a breakthrough program with a general improvement. And other had a specific area for the program, like care for elderly or reducing infection. So what about the participants? Each of the 51 teams had about 4 or 8 co-workers. That means that it was 293 co-workers coming to our workshops. But remember, it was many more people taking part of the improvement work at home. And the facilitators from the Center for Innovation and Improvement, they made their own evaluation as well. So, but the analysis of the data, the self-assessment scales were described into descriptive statistic by the time since improvement program was completed, and also with a significant, sustained improvement. And this was comparing to the facilitators' evaluation. And the significance for sustained improvement was 4 or more than 4 on the scale. And then we categorize all the structured interviews into actual improvement implemented and success factors. So this is the result from the teams. And here you can see the team's own evaluation from 2007. And as you can see, half of the teams have sustained significant score that is 4 or more than 4. I think that was surprising. Half of the team have sustained improvements. And then...
And these are the ones that were evaluated 3 years ago?
Yes, yes.
3 years after the program. Yeah.
So it's 3 years after finished program. If we then look at 2008, and this is 2 years after finished program, as you can see, the picture is more spread. Some are doing very well, and others not so well. And some did not go on with improvement work. And then finally, 2009, that means 1 year after finished program. It was a rather concise picture. I think it's a rather high score, even if it's only a quarter of the teams that have a significant improvement. So, worthy to note is that the score is rather high for those teams that finished their programs 3 years ago. And here you can see the assessment for the organization as well as the facilitators. And there is a slight difference between them. So what about the results? The results from the structure interview, actually improvements that was implemented. That was reducing waiting times in healthcare, more efficient management and referrals, improved hygiene in healthcare, and increased cooperation between different departments. And in the elderly program, we find a reduction of overnight fast and anxiety in the case of the elderly, and also better management of medicines in case of the elderly. This is some of the results that we found. So, Adam?
Yeah. Let's just ask you at this point of time in the presentation, can you identify with these results? Is it something that sounds very low or extremely bad or extremely good? Or according to, does anybody have a point there? Yes?
Did you find a reason why there was such a dip in the middle?
Let's just say it because it's a movie going on. So
Sorry.
say it again. You're on film. You're on camera.
Did you identify any difference in the sites or the services to identify those services that, why is there such a difference between 3 years, 2 years, and then I can understand why there's improvement in the first year because everybody's very keen and you get people, and then you would have expected to gradually tail off. So did you identify anything about the first lot of people that you worked with that meant that they continued so well?
I think I can only suggest that's our next research, I think. I think that reorganization and loss of a key person, that's something. And I think also the time aspect. You need time. We have seen so many teams finish their and completed their programs, and we said, oh, they won't go well. And then after a year, we were surprised because something grew. Yes.
Is there more questions over there?
Boy.
Thank you. This is really interesting, and it's really good to see these results. I'm interested that it's a self-assessment, and following on from this, did you do an independent exercise where you undertook whether the improvements lasted or, you know, etc., in addition to the self-assessment?
The question is if it's a self-assessment. Actually, it's both. It's it's an assessment from the organization as such, but also from the facilitator. That's so it's an assessment from the one leading or coaching the assessment. But then there is no evaluation yet comparing hard outcomes with this. No, it's not.
I had a question. The teams in 2007 versus the teams in 2009. How were the teams? Were they drafted? Were they volunteered themselves? I mean, how did they get in each of those cohorts?
So the question is, how were the teams selected to the cohorts? For instance, were there differences in selection between 2007 and 2008?
No, absolutely not.
But they volunteered to do it, or were they recruited to do it? Are they required to do it? I'm sorry, I'm from an independent system, and so ours is different. That they're not required to do it. So we found similar results when we did this, because our early adopters were the people that did great with this. You got farther along, and your results kind of tanked after a few years because you were dealing with people that weren't really innovators. And so I was really happy to see that, because we're feeling the same way.
Yeah.
So I wondered if you had that same experience.
Yeah, they're all volunteers. There are no ones that are forced to do this at all. They're all volunteers and searching to be with to join the improvement program. Yeah.
I think it's an interesting issue that she raised. From the Netherlands. I think it's a very interesting issue that she puts there, because I think that's something that's always with innovation work, that the first participants are, in a way, the easy ones, because they would innovate no matter what. You couldn't stop them with two horses for innovating, and it's very difficult to find the real interventions that get the second wind of people to get involved. And I think I wonder if other people are involved in that kind of work, because I'm an innovator myself and I always do this work, and I'm enthusiastic with the first round of people. But then it's so hard to find interventions that really work with the second group, that they really feel supported and get into the mood.
I can say something about that. I can say something about that, because we have made a lot of improvement programs, and we started at 2005. So there are programs before this.
Yeah, and I think it's two different aspects really, because what we clearly can see following the years of working with several programs is that it also the level of knowledge rises. So people come in with a different force really. They have more force and more empowerment often. So I think we can see a development definitely at the regional level also. So I certainly agree with you that the first ones are the enthusiasts, but it's also another aspect of that.
Yeah,
yes, I think
just have a bit of a contribution and a question. We've been working in England with lung cancer teams, and what we did in order to manage this issue of the innovators and the non was to randomize teams into a control and an intervention group. Unfortunately, I don't have the results as yet because we're finishing the project, but we hope. I mean, I'm not sure whether randomization of teams into QI intervention and not, we're using that resource enough as a way to understand, to take out the innovative, the desire to participate in something as a bias.
Okay, so if I understand you correctly, you're randomized to, how do you do a randomization?
We just randomly we did a randomization into a control, into a controller or an intervention group. So we randomized the teams. We just randomized.
But were they recruited voluntarily to be join the
We
study?
invited all the lung cancer teams in England, and around 60% said that they wanted to participate, and that 60% got randomized. So there is a level of interest, but then there is... So.
Yeah. It's difficult to do. Okay. Many questions.
To discuss later.
Yes.
Just a quick question then. I think this is very interesting, using this scale to assess how the teams or those who are forcing or who are actually doing the work. But did you use the scale for all the members, all the employees at the ward or the department where this change of work actually had taken?
It was not possible. We made it with the teams and the manager.
All
It
right.
was so important to have them with us.
Because then it's very hard actually to tell the real effect of the program. You should really, that's a suggestion.
Yes.
You should try to reach all the members at
Yes,
the
and
ward, for example.
I told you, they were 293 co-workers just in the teams, but there were a lot more involved in the program.
Yeah, it's a big work.
Well, anyway, but to reach some scientific strength or...
Definitely.
You should do it. Okay, thank you.
I think maybe we should... we'll have several points in time if we continue to do this, continue the discussion. So let's... I'll cut you here, and you'll have plenty of time to come back, because what also was part of the Ingrid's work was the work of success factors for sustained improvement. What are possible success factors for sustained improvement? And we'd like to please get your experience with us today. So if you can just join up in twos or threes. It should be possible. There are so many people. So at least twos, maybe threes, and bus for a little while, like 5 minutes, and talk about what, in your experiences, almost all of you have worked with improvement works. What are experiences specifically for sustained improvement? Is that a clear question? Does anybody? Yeah. So please, turn around or move a little. Find a partner to discuss.
Ska vi lyfta fram den?
Det räcker nog så här, va?
De är ju pigga. Behöver vi 2 mickar nu? Använder dem. Sladden där borta. Ja. De är aktiva. I beg your pardon?
Can I ask a question?
Yes, of course. But maybe...
The mic. Let's take it away.
Can we take it afterwards?
Jag ser det. Ja. Jag tycker jag har varit på något annat tidigare uppe också internationellt uppe i Uppsala. Alltså amning och så. Folk är rätt så sega, kommer inte igång och fråga. Nej, det blir ingenting av det. Så det är trevligt tycker jag.
Tycker det?
Ja. Jag är så glad att du pratar lite sakta så jag också förstår.
Ja.
Jag hade åtminstone kanske inte allt, men det står med. Jag lyssnade på något som heter Ann Fjellner innan i förmiddag som pratade också svenska från Stockholm. Eller så kan vi varandras melodi när vi pratar engelska eller vad jag ska säga.
Det gör så. En minut. 1 minute left. Okay. I'm very sorry to interrupt. I'll share my wonderful handwriting with you if you share your ideas with us. So are there any ideas for success factors for sustaining improvement work? Yes.
I think there needs to be, and hopefully you have it at the beginning, if not at the end, some kind of major driver, economic driver, I think, to that you get some finance, positive finance reimbursement for doing it. There's some cost saving or some proven target or something that you can link to it.
Yeah, that's a prerequisite for everything, of course. Yes, economic driver, more.
Okay, I think it's very important to continuously measure hard outcome data every month and to present the results for the staff members and maybe for the patients too.
For staff and maybe for patients. Measure continuously for staff and patients. Hard outcome. We got you. Okay, more.
Yeah, so my experience really is as a researcher at the big system-level quality improvement project we did out in Washington State. And, and that involved 600-700 community physicians. So it was a combination of pay for performance and improved care coordination. But I think that, you're only likely to get a sustained favorable improvement quality to the extent that physicians become interested and committed to the intervention. And that'll only happen if their clinical practice gets improved or is made easier somehow. In our case, we reduced the amount of paperwork that the physicians had to fill out. And we made available care coordinators to take care of the more difficult patients with these musculoskeletal injuries that oftentimes are hard to treat. And so they really saw the benefit to themselves, and so they became committed, and I think that was one of the keys to that successful intervention.
Definitely. Yeah? More? Leadership.
Successful projects overwork where there's actually clear leadership, something driving it.
So we had leadership, for those that didn't hear. Yes?
I think it fits in with leadership. We suggested that the facilitators are part of the team itself, stopping to rely on the central facilitators and getting the facilitators from within that team, and also using the information that they get through improvement to change guidelines or procedures so that everyone in the team is at the same pace, and maybe getting the teams to share in different collaborative meetings with other hospitals, and they know what's happening.
So knowledge sharing within teams here. Yeah.
Mm-hmm.
Yeah? More?
And it has to make sense to the persons involved, down to the lowest nurse or caregiving person. Everybody has to see the point of why making this change. Because when it makes sense to the person involved, they'll have a feeling of responsibility towards the job.
Has to make sense to everybody. Couldn't agree more. Yes?
Can I be cheeky and give you two?
Be my guest.
The first is, how easy or difficult is it to go back to the old way of doing things? If it's easy to go back, to slip back into the way we used to do things, then that's likely what's going to happen. So factors that we can build in to enable us to make the new way the default way will help us. And the other is to remember that the team that has done the improvement now won't be the same team in 2-3 years' time. There's new people coming in, so how are you addressing training and education of new staff into this way of doing things?
Thank you very much.
Okay. I think we have had a fantastic input to this.
Yes.
Extremely interesting to hear.
Research.
Yes, we'll change our program completely. Now, please, Ingrid, couldn't you show us just what our teams then?
Yes, absolutely.
Came forth with in their interviews.
What a lovely audience we have. So, this is our results from the structured interviews. As you mentioned also, the leadership is very, very important. So the clinical management must be engaged, and they must ask for results and support their teams in the improvement work. But it is also important that the co-workers have motivation and will to make improvement work. And it's good if you have a team with different professions, and a positive time spirit is also important. The support from the facilitators, and we found that it was important for the facilitator to visit the teams at home, at their own working place. Sometimes they met all the staff. And we also found that not doing too large reorganization, because then you might lose important key persons. And I would like to share with you a quote that might come from one of our teams, and it says, "We train hard, but it seemed that every time we were beginning to form up into teams, we would be reorganized." I was to learn later in life that we tend to meet any new situation by reorganization. And a wonderful method it can be for creating the illusion of progress, while producing confusion, inefficiency, and demoralization. Who said this? Well, it might be one of our teams, but it was Gaius Petronius, and he said this 2,000 years ago. What did we learn? So,
Thank you.
Adam?
I think that's a wonderful quote that most of us can identify with. Now, let's return to our themes and also our teams, because we want to show you our next film of a team that we're very proud of. They've been working with sustained improvement work for several years and managed to do several real improvements that can be measured hardly. And they have, and we want to show you really this as a, both of course you can identify success factors in the way of talking, but also a very good example of active leadership. So please meet the primary healthcare clinic from Landskrona, where they talk about what they think is important in their work.
Vårdcentralen Centrum är en akkrediterad hälsovårdsenhet med ett uppdrag för cirka 15 300 invånare. Vi har en bred mottagningsverksamhet med läkare, distriktssköterskor, barnmorskor, psykosocial kompetens och rehabiliteringskompetens. Sammanlagt är vi cirka 60 medarbetare.
Vårdcentralen har arbetat med förändrings- och förbättringsarbete sedan 2003. Vi vill skapa en vårdcentral som befolkningen gärna vänder sig till, men också en vårdcentral som vi alla kan vara stolta över.
Vi kan se att de största framgångsfaktorerna för ett lyckat förbättrings- och förändringsarbete är att man har en ständig dialog om verksamhetens mål, som naturligtvis ska sammanfalla med primärvårdens mål.
En viktig framgångsfaktor är vår egen medverkan. Att vi därigenom ser syftet med förbättringsarbetet och själva tänkt igenom hur det ska genomföras.
Det är också viktigt att ta tillvara den kreativitet som finns hos medarbetarna och som stimulerar dem att växa och utvecklas.
Här på vårdcentralen finns ett klimat där vi känner oss trygga och det finns utrymme och acceptans för våra idéer.
Vi måste våga pröva och tänka nytt. Och våga misslyckas.
En framgångsfaktor är också att det klimat vi har på vårdcentralen främjar samarbete mellan olika grupper. Vi har funnit att vi därigenom bäst tillvaratar våra patienters intressen och förbättringar och förändringar kan genomföras snabbt i kontakt med respektive grupp utan några långa beslutsvägar.
Som verksamhetschef ser jag det som viktigt att vara närvarande i arbetsgruppen och i förbättringsarbetet. Man måste vara medveten om att alla har inte samma takt i ett förbättrings- och förändringsarbete, men alla måste förstå syftet med den. Jag måste bejaka medarbetarnas kompetens och idéer, men framförallt så måste jag ge dem handlingsutrymme och ansvar och ge feedback.
Vi läkare uppskattar att det finns en öppenhet mellan professionerna. Att vi skapar forum där vi kan träffas och diskutera förändringar och förbättringar. Att vi har en rak kommunikation och att vi har respekt för varandras kompetens. Vi läkare är ju en del i arbetsgruppen, inte en grupp för sig.
Vi har ett positivt arbetsklimat. Alla har roligt här på jobbet.
Yes, as you heard, one of your key points are also our key points. And active leadership creates committed colleagues. And coaching management in facilitating improvement work is a good investment for the future, we think. So, Adam?
Yes. We'd like then to get your input. We were really touching this discussion before because we want to hear your ideas on what you really think of the IHI scale in the long term. So we will hand this out to you now.
Yes.
And the scale as such. And could you please send in the groups that you were before, or if you want to change to new groups, that's fine. Just think of one of your projects. Think of one of your projects where you've been doing change for several years, for instance, and try to get it into the scale. So if you don't have a project, then you can just discuss another project in the group. So try to assess your project with this scale. And in doing that, yeah, we'll just turn it up. So, please, just quite one moment more. I'll explain to you the idea of the exercise. When you have put a project into the scale, when you've graded a project into the scale, you can just discuss within the group what do you think are benefits, pluses, and what do you think are minuses with this long-term evaluation. We were into that, of course, before, but I think we could still get some more ideas. There were several still that were into two ideas. And please come with tips and ideas of how to do this in other ways.
Ska tillbaka till Henrik Lindberg kan vi ha. Ja.
Jag tror inte det går klart. Utan det kanske inte
Ska vi ta den efter? Det ser.
Fotografera av dem som Adam har skrivit. Kan jag fotografera av
Mycket
så
bra.
ser ni ju.
Mycket bra om du gör det.
Jag tänker vänta sen till ni är klara.
Det är så många som sitter kvar, det är jätteroligt.
Ja, men visst är det. Alla verkar så.
Vill ha samarbete, han vill att vi ska titta på hans arbete i England.
Margareta, vi kanske ska säga någonting om våra broschyrer. En halvtimme kvar. Halvtimme kvar. Den klockan stämmer inte. 13:44? Nej. Ja. Nej.
Om Adam skriver väldigt fort kan du väl också hjälpa till med de här? Ja, men också.
Ska jag hänga dem där borta då? Ja.
Det är sådana självhjälpare.
Ja, visst. Ja.
Okay. Let's finish up. Okay. Do we have any views on how it is to use the IHI assessment scale for a long-term basis, like this? It's involuntary participation.
No, it doesn't work. Take the other one.
No,
okay. That's better. Good. I hit it. That always works. Okay, so in Wales, we initially used the 5-point scale, but like you, we decided it wasn't sufficiently discriminatory, so we've moved to a 10-point scale now. We call it 1 to 10. And there are some similarities between our 10-point scale and your 10-point scale. You won't be surprised to know. One of the subtle differences is that the last few points on our scale, so 8, 9 and 10, so 4, 4.5 and 5 in your terms, are much more explicitly around spread. So you're talking about significant improvements and so on, and we're talking there very specifically about how much you're able to spread that across other parts of your organisation, and we give people some idea about what that might look like. So that's one of the things we do. The other thing is that we also have a focus on reliability, so you can only get beyond a 3.5 in your terms if you can demonstrate reliability in your pilot area. So that's another slight difference. I'll stop talking now.
Very interesting. Thank you.
Yes, here.
Yes.
It works.
Yes.
I come from Norway, and I've been working with the breakthrough series for several years, and we use this scales. And what we did for the last project, we combined it with a scale where you evaluate management and spread and sustainability. And I think that combination is actually very good. And if you also combine that with outcomes, then you really see the progress throughout the project. And the management support, I think, is a key element to succeed.
Is it a scale that it only evaluates management?
IHI.
Okay.
So I can think of a number of projects in our trust that would score a 4 on those, and they've been ongoing for several years. But they, on each of those projects, I can think of the driver of that project, the person who's energetic, who every time they take their foot off the throttle, things slide back, and you put their foot back on the throttle and you start seeing change. And my concern is that you could actually easily score yourself as a 4, but actually the reality is that the moment that person who's in the driving seat retires or moves on, that actually the whole thing collapses. So I'm not sure that actually you can rest on your laurels just because you've scored yourself as a 4 or a 5 after 3 or 4 years of sustained improvement.
I recognize that, definitely, that situation.
Hi, I'm from Denmark. We run a lot of improvement projects as well in our hospital. And I think this scale does make sense, but there are some challenges with it because it's based on an assumption that progress is linear, that you go through certain stages, and that is not always the case. For instance, sometimes you have an improvement project or a small project where it's so obvious and it makes so much sense to the frontline staff that actually you don't need leadership. So you're stuck at 1 if you don't need the leadership. Sometimes you don't need to educate people. You can have a consultant or something like that to go in and coach the team. So and sometimes if it's an implementation project, you don't actually need to test things. So sometimes there are some of these steps that you don't need. So progress is not necessarily linear. So I think that's one of the challenges with using this kind of scale.
Here.
My concern is that I'm not sure, while I agree with the idea of doing PDSA test cycles, actually in terms of making real improvements in overall care, whether ward-based things actually overall improve care in a certain area of health, and whether it doesn't seem to focus much on standards or guidelines and sort of the overall benchmarking of services against a set of standards of care. It's much more looking at smaller people sort of improving their way of practice. Does that actually improve the standard of care in the end?
So in a way it's too general, or is it...
I think it's maybe not general enough in a way, in that it makes you feel like you're doing something, but actually...
That's separate from the real work.
I wonder.
Also, I suggest if we can introduce how to measure the
the impact, not just the outcome. For example, if we have a program to control malaria, we have a different strategy to control malaria. One of them is to use mosquito nets. We distribute, for example, 100 mosquito nets. This is the outcome, 100. But the impact, how much this 100 mosquito net reduce the number of people ill. So I suggest if we can introduce an indicator to measure the impact, not just the outcome, because in the cycle there is an input, there is a process, and the outcome. But the next step is the impact of this outcome. If we introduce to measure the impact. Thank you very much.
A very clear point on the same line as the
Yes.
hard measures. We have no measure of impact, definitely.
Also, I have to come back to this, that this scale is only valid if you ask all the people who are involved in the project. Because if you, I think you said, ask the one who's the driver in the front seat or what you call the facilitator, you will of course get a much better result. So maybe this scale is more for administrative reasons to see if the units like you are working with, the Center for Innovation and Improvement, if you yourself think that this is a significant and successful improvement strategy. I think if you work on the floor, so to say, in the medical health care center or department, you really have to have other outcome measurements.
Yeah, you can't communicate this measurement and be
because
be
this
happy.
doesn't
No.
say anything on it only tells if you yourself think it has been successful.
So you mean it's and that's really the way it's been used in the breakthrough program, so that it should be a feedback
It's
to
not
the
the only one.
to the facilitator. So that's the way to use it. Yeah. Do we have any more? Yeah.
I think, of course, it's difficult to score it in a kind of objective way and to see what, because there are a lot of words in it that you can discuss a lot with people. What do you really think is evidence of what is modest and so on? But I think if we want to try to make it more objective or more independent, I think we're looking in the wrong way, because then you lose a lot of the worth that the list has just by discussing it with the team. Where do you think we stand with each other? You know, it's and maybe it's very unrespectful, but in a way it's like astrology. You know, it's like always nice to talk it over with people. What do you think you are, and what kind of capacities do you have, and why does it fit or not? And the discussion in itself is worthwhile. And I think that's the same with this list. It doesn't really matter where you are in a way, and of course there is an objective measure as well, but the most important effect is discussing it with each other, and we shouldn't try to make it more objective and trying to, you know, not involve people in scoring it, because I think that's just the real worth of it.
Yeah, that's an interesting point. I mean, because of course you have to communicate the hard data to all the people anyways. So I think that's a very interesting point. Yeah. There are at least 3 people here
I think she was
without
before
microphones.
you.
Hello.
Hello.
You are on. We don't actually use this scale, and really it's just offering an alternative, I think. Within our trust, we have a 5-step process. So we have set up and plan, which is around engagement, and you have a time frame for that to be done. Then there is discovery, so it's actually discovering what is the problem, what are the issues, what are the good things, what are the bad things, what are the patients saying. And then we go into design and trial, and this is a bottom-up approach, so it's with all of the teams. And then we go into implementation, and then we go into embed. But we have very, very clear time timescales around each of those individual key stages. So although we don't have scales, we have a 5-step process, and it seems to work extremely well.
What was this trust? Where do you...
Nottingham.
Yes, maybe
Yeah, if there aren't any...
I think we have
one last urgent... Yes?
I was just noting that the sharing and the long-term and the spreading is right at the end. In a way, you could bypass a lot of this by doing the sharing right at the beginning and implementing something that somebody's already done and tested. And there's little of that, I think, or certainly in my experience. Everybody's doing their own thing of this and not actually sharing it with each other.
It's like the gentleman over there, it's not a linear process, actually. I mean, you can have a lot of knowledge sharing with people who are not even halfway on this scale, of course. It's a very important point. Okay, thank you very much for this fantastic input.
Yes.
We'd like to turn back to our theme when we're finishing off.
Yes. And now to our third team member, and a very important one. Deming, we are very inspired by Deming, and he told us how important it is to involve the customers. And the more we learn about improvement, the more we understand we have to involve the patients in our work. And that is what we are striving to achieve. And now, Adam, who are we going to meet now?
You're going to meet Kina. Oops, no, sorry, you met IHI. You're going to meet Kina, who has been a patient that's been part of many of our development programs.
Som vårdgivare så vill man gärna erbjuda en vård som är både trygg och säker för patienten. Men jag tror att för att kunna skapa en sån vård så är det av yttersta vikt att jag som patient blir erbjuden att kunna delta i ett förändringsarbete. På detta sätt kan vi tillsammans skapa en vård som på ett bättre sätt motsvarar de behoven och de förväntningarna jag har på vården som patient. Detta leder ju även till att ditt jobb som personal blir mycket lättare. Det är just i mötet mellan dig och mig, där fördomar och attityder sticks hål på. I det mötet så ser du mig som en enskild individ och inte bara som en vandrande diagnos som kommer och behöver stöd från dig i ditt yrke. Jag tror att patientberättelser kan ge dig som personal ett inifrån perspektiv, men också inspiration att förändra ditt arbetssätt. Till skillnad från patientenkäter så har du som personal ett unikt tillfälle här att ställa direkta följdfrågor som tillfredsställer ditt kunskapsbehov. Som personal är du absolut proffs på ditt arbete genom den teoretiska kunskapen du har, men också via din yrkeserfarenhet. Men jag som patient, jag är absolut den bästa experten på just mig. Så är det av absolut största vikt att vi ser varandra som jämbördiga resurser som kan mötas och där vi kan lära av varandra. I Sverige så har vi olika projekt och utbildningar som syftar till att förbättra vården. Och i de utbildningarna där jag som patient har deltagit och delgett personalen min berättelse, så är feedbacken jag får att min berättelse är ovärderlig kunskap för dig som personal. Jag medverkade själv i ett sådant projekt där man vid utvärderingen sa just att det här hade jag aldrig kunnat läsa i en bok. Och det är just det som är så viktigt. Att den kunskapen som jag som patient har, den går inte att läsa sig till.
Okay. Well, we're finishing up. Do you have any spontaneous reactions to this issue of bringing in the patient into the development work, or for the whole session, actually? General points or ideas before we leave today? You've been extremely active already, so.
Yeah, very nice.
Do you use patient in your team? How many have directly the patient directly in your team? Yes, some.
I know in Denmark you are working like this.
Yeah, I can give it We're trying, but we find it extremely difficult to involve them in the concrete work. I mean, people are working in a very busy daily setting, and I mean, just organizing this with the patients and so on. Sometimes it's just a matter of catching the doctor or the nurse when they have the time. So there are a lot of practical problems with involving the patients, as far as I see it, but we try to.
That's one.
Hello, my name is Ita O'Connor. I'm from London, although I mightn't sound like it. And my job is trying to engage with staff predominantly in reducing infections around vascular devices. And I've started with the nurses, and then I moved on to the doctors, and now I've moved on to the patients.
Oh, that's
because the patients are the ones that will tell me, and they will make sure that it's done properly. It's all about engaging with the patient and saying, if it's not done like this, get them to stop. And I think that's what's making the difference. And we have made a difference, and you'll see it on one of the posters outside. Thank you.
Yes.
Okay.
It's time to end.
Thank you very much for all your input and the fantastic discussion.
We are very happy for your participation and all your very good ideas. We are going on in some way. Thank you very much. And thank you, Adam, and thank you, Ingrid. And if you want some information about us, you can put it on here. Thank you very much and have a nice afternoon.